Good afternoon, everyone. Thank you for coming to this Lunch, Learn, Link seminar. As many of you know, we have this seminar probably once every month and twice in some months. And we try to bring a variety of topics around cancer prevention and control in particular, and developments in basic science and clinical work that has application to population-based work. So welcome again. I'm Norma Kanarek. I manage the Maryland Cigarette Restitution Fund Research Grant at Johns Hopkins, and that's actually the sponsor of this activity. We broadcast the lecture over the internet, so we have audience from Howard University and University of Maryland for starters. Often there are other universities involved too, so we welcome them and the Department of Health, the Maryland Department of Health. So anyway, I'm here to introduce Catherine Burdalski, who with her partner Joy Feliciano have received Cigarette Restitution Fund research grants. We have a cycle where we request a grant proposal, probably due in the first week of April, second week of April. That's when we know the Maryland budget is all set, and then we get the proposals, they're reviewed, and a set of awards are made. So this is a unique project that Catherine and Joy embarked on with an application in a pharmacy setting. So I think it's very interesting, and we're hoping to learn a lot from this, not only here at Hopkins, but for statewide applications as well. So Catherine Burdalski is a pharmacist, a clinical pharmacist, and works at our Bayview hospital. And she is a preceptor and mentor to a number of pharmacology students from the University of Maryland, correct?
And Shenandoah University and Notre Dame University.
Okay, so from a number of universities, and so you'll hear about how they've played a role in rolling out this tobacco cessation intervention. Just a plug for November as the Great American Smokeout Month. If you have connections to programs and all, think of the Maryland Quit Line, 1-800-4-CANCER, and you can be put in touch with some smoking cessation services, including free nicotine replacement medications. So please welcome Catherine Burdalski.
Hello, everybody. And thank you, Norma and the School of Public Health, for providing the opportunity for us to discuss our pilot program today. It's a pleasure to be here. Just a quick disclosure slide. I truly have no disclosures other than we have graciously received funding from the Maryland Cigarette Restitution Fund here at Johns Hopkins for partial fiscal year 17, and then full years for 18 and 19. Tobacco is a well-established risk factor for multiple types of cancers and many other chronic disease states. This illustration from the 2014 Surgeon General's report on the health consequences of smoking, a 50-year update, highlights the disease states that are causally linked to smoking. The ones in red are the new additions for this report, and although November is, as Norma said, the Lung Cancer Awareness Month, and our intervention does focus on an oncology population, it is imperative that we recognize that the far-reaching nature of this chronic disease state known as nicotine dependence. As a healthcare providers, our intervention in smoking cessation may at times feel small, perhaps not worth it, or perhaps we're under the impression that somebody else is taking care of this. But it can have huge impacts on the patient's mortality, quality of life, and unnecessary healthcare utilization. In the next 45 minutes or so, I'm hoping you will be able to associate the available literature in developing a smoking cessation service, differentiate the key components of a smoking cessation service and their applicability to perhaps your practice areas, evaluate a pharmacy-driven smoking cessation pilot program, mainly mine, and adapt the service to your relevant healthcare environment. Historically, as providers, we actually do a poor job in performing an adequate tobacco assessment, let alone creating an intervention and plan. In a 2012 study of 155 actively accruing clinical trials by the National Cancer Institute, less than 30% of trials assessed any form of tobacco use at their enrollment. And this included lung and head and neck cancer trials as well. If you consider our social history in our electronic medical record used by our health system, although it's required completion per Joint Commission standards, it actually lacks the true detail required for an appropriate tobacco assessment or identifying risk factors for patients at a greater risk of relapse on their cessation journey. Additionally, the responsibility of completing this section in the electronic medical record is actually shared by a number of different healthcare providers. These providers could be patient care technicians, nurses, or our physicians. And this varies based on the outpatient facilities that are using it. So as you can imagine, this creates a lot of variability in the assessment and the utilization of this information. With this knowledge that we actually don't do a great job in thoroughly assessing tobacco use, it may come as no surprise that there is literature to support the known barriers in assessing and counseling these patients for tobacco treatment services. Aside from the electronic medical record limitations, provider time and workflow constraints in our ambulatory clinics are barriers that are well known to our outpatient settings, and they experience them every day. The focus revolves around keeping these clinics on time and increasing provider RVUs. Additionally, in a 2012 study of over 1,100 physicians from the International Association of the Study of Lung Cancer, physicians actually admitted to varying degrees of comfort level when providing different facets of tobacco treatment services. Where a large majority of physicians admitted being comfortable in asking and assessing patient tobacco use, only 35% of physicians felt comfortable educating patients on the tobacco treatment options and referring patients to the available resources for additional tobacco treatment services. So this highlights a larger problem. There is a need for more education for healthcare providers on tobacco treatment services and that are available in their region. As we recognize our barriers to care and our weaknesses in providing an appropriate intervention, it's also important that we gain more knowledge on our target population that we intend to serve. A study published this year that looked at the prevalence of smoking cessation behaviors in adult cancer survivors pooled around 2,500 patients that were cancer survivors, and aimed to elucidate some of these demographic highlights and behaviors of their tobacco use habits. This helps us understand the target population and who we would be working with in our different healthcare settings. And you can see here that our target demographic, those current smokers, are actually typically less than 65 years old. They are usually less educated. They perhaps are uninsured or underinsured, or they are Medicaid recipients. But the majority of these patients want to quit, and less than half of these patients are actually utilizing the cessation assistance or tools that are available to them to help them quit. Those that were not captured by this survey from this year were actually our patients that are often overlooked but do require additional support in their cessation journey. And these are patients who are at high risk of relapse for their smoking cessation. These are typically your former smoker category, which is a large category of this target demographic. A lot of patients that have recently quit or perhaps they're experiencing a traumatic event, need additional support in their cessation journey. We also have a unique group with the lung transplant patients who, after they've received their transplantation, may have a newfound appreciation and joy of having that cigarette with their new lung capacity that they haven't experienced in some time. Unfortunately, our electronic medical record system, as of now, does not allow us to readily identify this high-risk population, and it requires a little bit more of a thorough assessment. Once we have identified our target population, there is excellent and ongoing work at the Medical University of South Carolina on smoking cessation and how to make meaningful interventions. There is data to suggest taking an all-inclusive approach, also known as an opt-out approach, is feasible and can have a positive impact on short-term cessation outcomes. This group took an adult inpatient population who were self-reported current smokers and offered all patients bedside counseling as well as post-discharge follow-up. In patients who were not reached for that bedside counseling on the inpatient side, they were still available to receive the post-discharge follow-up. Over half of patients who were able to be reached via phone at the 30-day time point reported abstinence from smoking, which is quite impressive using this intervention. Some more interesting items that came out of this study were that only one full-time counselor was used to complete all of the bedside counseling. This person was able to reach 35% of the available patients, which was almost 3,000 patients in 15 months. I found this to be quite impressive. And since then, in talking with the Medical University of Southern Carolina, they've actually expanded to another bedside counselor as well. We also see that between the bedside counseling plus the post-discharge follow-up, they were able to capture over 60% of the patients and allow them to receive tobacco treatment services. As you can imagine, those that received bedside counseling were associated with an increased response rate in the post-discharge setting. Probably most importantly, and one of the things that I took away from this article was that less than 1% of patients who were eligible for follow-up requested to be removed from the service. And this is what really highlighted that an opt-out approach was successful and can have impact on patient outcomes. Another valuable, no pun intended, study published this year from those colleagues at MUSC looked at the similar intervention, but we're focusing on hospital readmission rates among current smokers who were exposed to the intervention. Again, this intervention is a little bit unique in that they implemented this automated tobacco treatment service. They included a registry component, as well as the post-discharge follow-up that I've been mentioning was actually an interactive voice recognition technology, or IVR technology. The registry interfaced with the hospital's admission and discharge records to be able to identify the population, and then the IVR technology took care of the follow-ups. The intervention of a tobacco treatment service was further defined into those patients who received a high level of service versus those who received a lower level of service, but both received a tobacco treatment service. The high level was defined as the bedside counseling plus the IVR, and the low level of service was simply the IVR at post-discharge, for post-discharge. The IVR follow-ups were standardized to address patients at 3 days post-discharge, 14, and 30 days. And what they found was quite impressive. I hope this can broadcast appropriately. But as we see, the patients who received any tobacco treatment service intervention experience less 30-day readmission rates, which was found to be statistically significant than their control group. And we also see improved 30-day readmission rates with those who received the bedside counseling plus IVR follow-up. And just as a reminder, reduced 30-day readmission rates is savings for our institution. Although they were not technically statistically significant, it's a good thing to note that at each of the time points, the intervention arm was actually still found to have more improved readmission rates for our patient population than the control. I think this shows that this is definitely a valuable intervention to provide for our patients. It also highlights the importance of close follow-up with these patients in the post-discharge setting, because close follow-up can relate to improved success rates for our patients. Of course, smoking cessation interventions are advocated for on the national level, and in this year, a survey from the Centers of Disease Control and Prevention reported that more than 80% of oncology providing hospitals reported having tobacco treatment programs. About 85% of these hospitals, of this group, were NCI designated cancer centers. And this is excellent to see such a majority, but why not all NCI designated cancer centers? Across the board, national organizations all encourage evidence-based approach to tobacco treatment, including a combination approach with both pharmacologic intervention as well as behavioral therapy management. Even with this information, it's still up for debate on which healthcare providers are best suited to provide this service. There's a rapidly growing interest in expanding the pharmacist's role to tobacco treatment services in Maryland and nationwide. Unfortunately, Maryland does not currently recognize pharmacists as healthcare providers. There are two bills listed here. The first bill is a bill that's going through Congress, and the second bill is a Maryland state bill. The first bill is a bipartisan bill that would aim to amend the Social Security Act to recognize pharmacists as providers under Medicare Part B. This would allow ambulatory patient care services to be reimbursable under Medicare Part B if they were provided in a medically underserved community by a pharmacist that's acting within their scope of practice. So this would be extremely exciting for our nation to be able to add pharmacists to our list of healthcare providers. Also of note, 23 of Maryland counties, including Baltimore City, are actually considered medically underserved and could benefit from this. The second bill would allow pharmacists to work with insurance companies to provide FDA-approved cessation aids to their patients based on the formulary of those insurance providers. And this bill is actually very similar to other bills that have been successfully passed in other states across our nation. One example is New Mexico. And we as pharmacists can provide a valuable intervention and extension of clinical patient care services. There are over 15 published studies on the effectiveness of pharmacist-delivered tobacco treatment interventions, and two studies that I happen to highlight here focus on interventions provided in a community-based setting, with similar quit rate assessment time points. On average, the quit rates from other healthcare providers, including physicians, nurses, dentists, is approximately 20%. And you can see here on this table that the 30-day quit rates are actually there or a little bit above when pharmacists provide this intervention. Just to explain some of the differences between the two studies, Dent and colleagues compared the pharmacist intervention group to a standard of care, meaning their telephone intervention group, and provided biochemical confirmation of cessation using urinary cocaine levels. But they did not provide any assistance with access to nicotine replacement therapy or other cessation aids. Kahn and colleagues did not provide a control group for comparison, and also did not provide any biochemical confirmation of adherence, but they did provide some financial assistance to their patients towards their cessation aids. And while both studies are an example of improved outcomes, we can see when smoking cessation is provided for our population with a pharmacist intervention, I do want to reiterate that I believe it's important for all of us as healthcare providers to provide this intervention, not just pharmacists alone. And pharmacy learners are an extension of the pharmacist. The Accreditation Council for Pharmacy Education, or ACPE, creates educational outcomes for colleges and schools of pharmacy, and these outcomes are often focused on targeting public health-related activities such as counseling for disease prevention and outcomes. And the pharmacy curriculums for both prescription and over-the-counter medications include counseling, education, and training, especially for nicotine replacement therapy, but it also includes motivational counseling and counseling on the 5 A's model. Student pharmacists gain both didactic and hands-on experience in the lab setting to these elements, often in their last 3 years of schooling. So their proximity to learning this information and applying it is very close, and I think that's important. Of note, for all of the pharmacy students, their last year of schooling is required to have this real-world rotation experience designated as advanced pharmacy practice experiences, and they are they give the opportunity for students, as still students, to provide the application of what they have learned to the patient care setting. I also wanted to briefly mention the great work of the School of Pharmacy at UCSF. They have created what is called RX for Change. They've basically adapted the United States Health and Human Services guideline for treating tobacco use and dependence and created their own clinician-assisted tobacco cessation modules. This helps train not only current pharmacists, but also their students as well. So we've discussed a lot of great literature that I've reviewed in the past few slides. And just to summarize, the key takeaways for a valuable intervention after I had assessed all of this information and that I wanted to share with you are that we need to be able to standardize our tobacco assessment and be able to easily identify our target population. And this is most helpful when your electronic medical record system can work with you. We should be able to engage in a multidisciplinary team and, when possible, engage your learners in an academic setting. Also, we want to create an opt-out approach, include all eligible patients, allow the patients to tell you when they no longer want to participate, and this can help improve success rates. Finally, we want to provide a close and intensive follow-up with these patients. And as we have implemented and adapted our program, we've really taken these valuable pieces of intervention to heart. As we transition to talk about our intervention, I wanted to provide some context of where we've been and where we're going. The beginning discussions of this program started in December of 2016, and the subsequent months we presented to leadership in both our Department of Pharmacy as well as our Cancer Center, and explained our plan for implementation of a pharmacy-driven smoking cessation service. Our approach was definitely multidisciplinary. We engaged a medical oncologist, nurse practitioners, our nurses, our nurse manager, as well as many other pharmacists and clinical pharmacy specialists. Our goal was clear. We wanted to establish a tobacco treatment service for our key population in the Cancer Center while making our learners indispensable. And although we started off small in piloting and creating infrastructure, the plan is to, from a high-level overview, to transition to offer this pharmacy-driven smoking cessation service to all eligible patients. A little bit of background for those of you who are not familiar with Johns Hopkins Bayview Sidney Kimmel Comprehensive Cancer Center. We are an ambulatory-only setting. We do not provide any inpatient oncology services at this location, but we are considered a center for excellence for upper aerodigestive cancers, and this includes lung cancer, esophageal cancer, thymic carcinoma, and carcinoid tumors. Although we treat many other cancers, these are the majority of patients that we see. So when we started the program, I'll focus your attention on the left side for right now. We started in one clinic. We knew we needed to start small, allow the learners to get adjusted, allow us to get adjusted, and then plan to expand moving forward. We initiated the program in our multidisciplinary clinic for thoracic malignancies. This is a once-weekly clinic that occurred on Wednesdays, and the majority of the patients that we see here, although it's not all of them, the majority of patients are newly diagnosed with a malignancy at this time. It is a single clinic, but it's a very long and intensive clinic. The clinic is academic-based, so it encourages medical residents and fellows, nurse practitioners to come in the morning, assess and evaluate patients, completing their history and physical. Then these patients will undergo a general oncology education session led by one of our nurse practitioners. During the lunch hour, their individual patient cases are discussed with our multidisciplinary group. And this includes a medical oncologist, thoracic surgeon, and radiation oncologist, although there's many other people that are contributing to the conversation. There are radiologists, pathology, pharmacists, and nursing, and research nursing as well. And while we felt it was important to start in this clinic because of the longitudinal nature that the patients are there, typically patients are there for about 8 hours. It starts around 8 o'clock in the morning and will go into 4 o'clock in the afternoon. The patients find it valuable because they're able to see all 3 of these providers on the same day, and they're able to have confidence in the plan of action to manage their cancer moving forward. We felt very strongly that tobacco treatment services should be a part of this plan. This is why we chose this clinic to start off in. So the majority of our data, I'll say, is within this clinic, but in March of 2018, we were able to expand to the thoracic surgery and pulmonary clinics, which I'll call Surge Pulm, on our Thursdays. So we expanded to another day of the week and 3 additional clinics. We wanted to capture a population that was either diagnosed with early stage cancer or that was in a precancerous setting. So that's why we included these 3 clinics. One of them was a thoracic surgeon that was seeing patients, interventional pulmonology, and pulmonary nodule clinic. And this, as you can imagine, increased our patient load dramatically. So we had to be a little bit more creative with how we screened and assessed each patient and how we implemented our intervention. And I'll talk about that in subsequent slides. So just a high-level overview of the plan, of the program's plan. Our pharmacy learners are really our boots on the ground, and they complete all of the patient assessments, do the documentation, and all of their counseling and actions, direct patient care actions are overseen by a clinical pharmacist. Again, they'll screen patients via phone in some cases as well when we don't have the time to always screen them in clinic. They'll offer the tobacco assessment and determine when patients are eligible to receive cessation counseling. It is an opt-out approach, so we do screen all patients and offer the program to all patients who come through these 3 clinics, and they're able to let us know if they do not want to participate. Finally, the students again complete the counseling and provide all documentation on these interactions. Just to make it explicitly clear, patients who are eligible to participate in our program include those that have an appointment in one of the available clinics that I discussed, and they have to be either active smokers or former smokers that have quit within the last 90 days. And again, that's in hopes that we are capturing this high-risk population that at a critical diagnosis point may be at a greater relapse on their smoking cessation journey. The intervention that our program provides is not groundbreaking. Actually, management of smoking cessation really hasn't changed much over many years. So here's the list of interventions that our students are able to provide. And as you can see, they're well educated based on their training to provide this intervention in the different medication and motivational counseling areas. One of the areas we absolutely wanted to account for, but are not necessarily professionally trained in, is the behavioral therapy management. So in order to accomplish this, we reach out to local support groups that provide individual and group counseling sessions, making sure that they're still viable, and providing those resources, phone numbers, addresses on our educational information. We also, for all Maryland residents, provide the Quit Now card so that patients, and explain what the service can provide so that they're able to have access to this as well. And although we're providing a standard of care intervention, I'd like to highlight that really the way we're providing it was truly the intervention or exploration part of this whole program. We created a standardized assessment tool, what we call our clinical pathway, to allow a standardized assessment for the students to be able to easily digest the tobacco assessment process, understanding that they'll use this for each individual new patient, but they quickly learn that they'll need to adapt their assessment and perhaps their plan as patients go through their cessation journey, because everybody is an individual and everybody reacts to medications differently and has different needs. So it's actually a great learning experience for them. We do provide intensive follow-up. Often this is done via phone, but when available and patients are coming in for perhaps their treatments or their provider visits at the cancer center, we do provide our follow-up interactions in person as well. And when I say intensive, I absolutely mean intensive. The frequency of our attempted interactions with our smoking cessation patients start with every other week for the first 3 months, and then at the 6-month, 9-month, and 12-month time point. We do have a caveat for patients who may need some additional help at that 3-month time point. If they are still smoking, we're able to continue the every other week follow-up with them up to 6 months. And I wanted to highlight the difference in the workflow between our multidisciplinary clinic intervention and our surgery pulmonary intervention. Here you see the patient workflow for our multidisciplinary clinic. You can kind of see that they arrive to clinic, they get vitaled. First thing in the morning, we try to catch them for their tobacco use assessment and not only provide our documentation in the electronic medical record, but update the social history as well. Then they're seen by another learner to receive their history and physical and go to group teaching. They have lunch on their own, and the group meets for multidisciplinary lunch to discuss the individual patient cases. And then in the afternoon, for the eligible patients, they receive their counseling and their smoking cessation kit that they get to take home with them. Finally, we kind of sandwich in between the different provider visits that the patients have to be seen by in the afternoon. So this is specifically the learner workflow for our multidisciplinary clinic. And you can see that there's many different steps throughout the day, so it is an active clinic for them. And they have different responsibilities given the different times of the day. They take full responsibility for watching their patients, monitoring for their arrival, making sure they review their patients prior to them coming in, conduct an appropriate tobacco use assessment, and assess them to see if they are eligible for the program. In patients who are eligible, they do offer the program, but say that they will come back in the afternoon should they accept and provide additional counseling. At that point, the learners come back to the pharmacy and discuss the patient, the individual patient case and their plan for the patient, and it's always confirmed by a clinical pharmacist. They'll attend multidisciplinary lunch and contribute to the conversations that are going on about the patient case. And then in the afternoon, it is their job to coordinate counseling the eligible patients, documenting, as well as doing phone call follow-ups for those who are already enrolled in the program. Our Thursday clinic or Surge Palm clinic is a little bit different for our pharmacy learners. Since we were increasing our patient workload substantially, we wanted to create a more efficient way to assess our patients. We started with screening our patients via chart review and determining if we had enough information to decide if they were potentially eligible for the program. In those patients that required more information, or for those who were eligible for the program, they would then go through a phone screening process so that we could do an appropriate tobacco assessment for them over the phone. On Wednesday, they would make a list of the available patients that they would see in clinic, and only those patients who were potentially eligible for the program. There's a small caveat here. If we were not able to reach patients via phone, they would automatically be seen in clinic. On the day of clinic on Thursday, the providers move very, very quickly. Some of them only have 15-minute blocks to see their patients. So it's the learner's responsibility to monitor closely the arrival and rooming of the patient and to interject before the physician goes in to see the patient. Usually we have about a 5 to 10-minute window, and we have been successful in implementing, from an anecdotal standpoint, this intervention and not being able to hold up the clinic visits. All learners, before they provide a direct patient interaction, go through a rigorous competency. They are provided education materials prior to their rotations, so prior to them even being on campus. And then the first day of their rotation, during their orientation, they're expected to complete a written competency exam and a mock patient interview. After that, learners are then observed for their first patient interactions, both in the interviewing process and in the counseling, and this is typically done by a clinical pharmacist. There is a remediation process as well for students that may not pass the written patient assessment. So for about the last year and a half, we've been capturing metrics on our capture rate, as well as our acceptance rate of patients who allow a pharmacy learner to perform a tobacco use assessment, as well as counsel them on the smoking cessation program. We've talked a lot from a subjective standpoint about the feasibility of implementing a pharmacy program. We've conversed with all the different layers of our ambulatory clinic, making sure that we weren't disrupting clinic workflows. And also, as we looked at our follow-up rates among our patients, we were observing quit rates at the different time points. So here is a summary of our results thus far. This was after about a year of data, so we have a little bit more that we've accumulated from this time point, but this represents approximately a year. So what's good to see is that we're able to capture about 88% of our patients that come through these clinics, which is quite impressive. If you recall, in the inpatient intervention at MUSC, they were able to capture approximately 60% of their population. And patients were very accepting of our intervention from a student pharmacist or pharmacy resident. So almost 100% of patients allowed a pharmacy learner to enter their exam room and provide a tobacco assessment. And over 70% of our patients allowed a pharmacy learner to provide cessation counseling for them. So on the right-hand side, you'll see our graph for the follow-up of our patients across our different time points. We highlighted the 1 month, 3 month, 6 month, and 9 month time points. Of note, this is a rolling admission for the program, so you will observe less number of patients as we go through time that have completed up to 9 months in the program. And you'll also observe that the gray sections are patients who were unavailable for follow-up at this time point. What I'll talk about later is one of our biggest challenges that we recognize is following up with patients via phone and the success rate of that. One thing that I'm hoping that you're catching from this slide is that patients who were smoke-free at that 30-day mark. So anecdotally, we see that over 40% of patients, so 14 out of 32 patients, were smoke-free at our 30-day time point, which is much improved by when we consider the average quit rate, 30-day quit rates for other healthcare professionals, and the quit rates that were examined for pharmacists. So in the future, actually, it's happening now. This year, we're looking at our true quit rates and comparing them to a historical cohort to see if our intervention is truly successful, and we suspect that it is. We're also looking at sustained quit rates, so observing if these patients are quit at 30 days and at 90 days, but may have had a relapse at 6 months, what could we have done within that time frame, perhaps more intensive follow-up, that would have assisted that patient? Also, from an outcome standpoint, we're interested in the increased healthcare utilization and hoping to see if patients who are involved in the program perhaps use some of the healthcare resources a little less than others. And this would be a mark of the hospitalizations, as well as for our cancer population, transition to next-line chemotherapy or immunotherapy. I think I have a little bit of a biased view, but I believe we do a few things really well. I'm really proud of us being able to engage our learners. And as an academic medical institution, I think this is definitely part of our sustainability. We will always have learners around, and it helps them in their learning process to have these direct patient interactions. We've been able to successfally implement an opt-out approach, and through the generosity of the Cigarette Restitution Fund, we've been able to decrease financial barriers to care. So within our program, a small portion of our funding goes to purchasing nicotine replacement therapy, so that for appropriate patients, we're able to provide them NRT free of charge, which is really wonderful. We also take a multidisciplinary approach, as I talked about the diversity of our team, and as explained previously, we have quite intensive follow-up. A couple of areas that I think we could definitely improve on is our area of behavioral therapy management. I'm hoping at some point to engage, once we get a little bit more established, to engage psychiatry in their involvement and perhaps create a referral source where we can have patients who are seen within our healthcare system refer to oncology when they're enrolled in a smoking cessation program. Also, identifying patients at high risk for relapse. I'm hoping to improve our electronic medical record system to help identify these high-risk patients, as I think this will be key into decreasing our tobacco use rates overall. I'd also love to create an avenue where patients and their caregivers potentially can opt into the tobacco treatment services that we can provide. There's been great movement in our at Johns Hopkins Bayview in the Department of Pulmonology, where one key physician has taken it upon himself to start seeing specifically smoking cessation patients within his clinic, and I really find this admirable. Since he started doing this summer, we're able to refer our patient caregivers and family members to his clinic for additional support. Also, we want to maximize our follow-up interaction. Although we provide a great intensive follow-up, obviously our phone interactions sometimes fall below par. It's very challenging for us to reach everybody via phone for the amount of patients that we have on service. So I'd like to start to think creatively on how we can maximize this interaction. From a sustainability standpoint, I think a lot of what we're doing now, just by educating other providers and those who are in different healthcare settings on managing managing nicotine dependence as more of a chronic disease, I think helping to kind of shift that mentality is going to help make tobacco treatment services a more sustainable option. Also, especially after experiencing our intervention, I think providing ease of access to medications, such as something simple as nicotine replacement therapy, is also key for the success of our patients. So just to give you a little bit of insight, a box of a 2-week supply of nicotine gum costs about $30 to $40. And we often recommend using a combination approach. So a long-term acting nicotine replacement therapy plus a short-term acting nicotine replacement therapy. So when you're asking patients to spend $80 every 2 weeks, that cost can be a huge barrier to care. We're hoping to increase the number of trained personnel, not only from a learner standpoint, but also engaging our nurses, our medical students, and really expanding our reach. I think this will help us in expanding the number of available people who feel that they are able to provide a tobacco treatment service. And of course, some of the key things that we would require for sustainability are established funding, and I would love a location to be able to see these patients in more consistently. Right now, we integrate ourselves into current workflow, which can definitely have its challenges. So in the future, we hope to expand to all oncology patients at Johns Hopkins Bayview, and then hopefully throughout the health system. And I think one of the areas that I really would like to push to work on is optimizing our EPIC functionality to be able to identify our target population, as we previously stated. I love collaborating with interested groups, and I'm happy to give talks on our intervention, but also on the need to help addressing this public health issue. And also, I hope at some point that we can expand smoking cessation services to all patients, including an inpatient setting where there's a lot of our established data, and to other outpatient clinics. This work was truly made possible by many, many hands. I'll go through a few of them, but it is wonderful that we've had the support of the Cigarette Restitution Fund for this year, and the support in previous years as well. I'd like to thank my team. Our smoking cessation program is made up as many people as we had previously discussed. We are currently writing up this information from a feasibility standpoint, and hopefully soon from a results and outcomes standpoint. I'd also like to thank different departments of Johns Hopkins Bayview, the Department of Pharmacy, the Sidney Kimmel Comprehensive Cancer Center, as well as the Departments of Pulmonology and Thoracic Surgery. Finally, thank you to all of the individuals across the health system that have allowed us to share our story in your different healthcare settings. We're happy to continue to do that. And then finally, this program wouldn't be possible if we didn't have our pharmacy students, and if we didn't have our patients who are willing to participate, and their caregivers to support them. I'm happy to take questions at this time, and I thank you all for your attention. Again, my name is Catherine Burdalski, and if you would like to follow up with me outside of this forum, my email address is here for you. Thank you.
Thank you for that wonderful presentation and for the impressive work that's currently being done. So I actually work at the Kimmel Cancer Center here downtown. And one of the challenges that we face with lung cancer patients in relationship to smoking is cost, which you mentioned. And I'm just curious to know, for the nicotine replacement therapy plus counseling that was provided as an intervention in your study, who was responsible for paying for that? Was it the study, the patients? Because I'm aware that depending on the insurance company, sometimes it's, the burden goes back to the patients, where the insurance company considers nicotine replacement as an over-the-counter medication and they won't pay for it. Yeah. So I just wanted to know who actually was responsible in your study.
Thank you for that question. And just to reiterate, the question is who was responsible for the cost of our intervention, basically seeing the patients as well as the NRT that we provided. And you're absolutely right. Cost is a huge barrier here, and often insurance companies will not cover over-the-counter medications. So for our intervention specifically, we had the liberty of the budgeting for nicotine replacement therapy in our Cigarette Restitution Fund grant. And that allowed us to provide, to eligible patients, that allowed us to provide nicotine replacement therapy to them free of charge, and we're able to sustain that for the year that they are on the program. So that was truly a blessing and a wonderful piece. I think it is definitely attributable to our high success rate. We did not do any billing from a seeing patients in clinic standpoint. Pharmacists are not considered providers in the states of Maryland, so we are not able to bill for any services at this time. So we were basically trying to see the patients within different provider visits and documenting that we were seeing the patients but not dropping a charge for them.
So I'll just add a little piece about research. There are research expenses that Catherine has incurred, and in real life, it's not a research study. So how do we attack this barrier to care? So in Maryland, there is a program called the Quit Line. I mentioned it early on. People who are referred to the Quit Line by their physicians, or who call the Quit Line themselves, will be enrolled in the program and be afforded these nicotine replacement therapies, and even varenicline if they have a doctor's prescription. So in Maryland, we do have a program that will pay for it. I'm sure Catherine knows that there's a big benefit to giving the patient those tools right away when they say, I'm ready to quit, I'm ready to use the patch. And whereas for the Quit Line, there's a process. So they call, they get called back, there's a registration, then the replacement therapies are mailed out. And so that could easily take 10 days. So I think one aspect of this is, of the differences really are that Catherine's addressing the issue right then, and whereas for the Quit Line, it's a little more drawn out, though, a first step could be the planning. But we're going to compare the pharmacy numbers with the Quit Line numbers. Right now her quit rates are really quite good. So we'll see. But you have a follow-up question.
Yeah, just as a follow-up. So again, we do see a lot of lung cancer patients in the clinic, and I'm glad you mentioned the Quit Line, because I had a patient, for example, who newly diagnosed with small cell lung cancer, was referred to the Quit Line, and it took more than 2 weeks, actually more than 3 weeks, just to go through the process. And she got really frustrated and just couldn't afford, the nicotine replacement treatment on her own, and still continued to smoke. And so I am just curious, I think you guys are doing a wonderful job, and it'd be great if we could expand that even beyond Bayview. But I'm just wondering if there are any other programs at Hopkins, other than the Quit Line, that we could refer patients to, especially downtown, if you're aware of any.
So I'm not aware of any downtown at this time that provide tobacco treatment services, but would love to, if they do exist, would love to collaborate with them as well. As I may have mentioned in the course of the presentation, at Johns Hopkins Bayview, there is a pulmonary physician in our asthma and allergy center that has started seeing patients specifically for tobacco treatment services. And between his intervention and our intervention in the cancer center, those are the only two that I'm aware of at this point.
There are research studies, right, Catherine?
Yes, there definitely are, yeah.
In particular, out at Bayview.
Yes.
So having to do with behavioral health and treating addictions, including nicotine addiction. But it's really just for the period of time that they're enrolled in a study, and not on a continuing basis. Yeah.
I do think your question highlights an unmet need that we have on across campuses that we can definitely improve on the tobacco treatment services that we afford our patients. And I can appreciate your story about your patient who became frustrated when trying to get through to the Quit Line. They have a specific process in place, and it's fantastic that they're able to reach out to so many patients and afford nicotine replacement therapy for those patients, but it does take time. Sometimes it helps for us to gain a better education on the true process with the Maryland Quit Line, and to explain to the patients that this may not be an immediate need that is met, but will be something that will be beneficial to them in the future, and they shouldn't get discouraged.
So how many of you are clinicians and work with the electronic medical record here? So just one. So for background, for the non-clinicians, there is a program linked to EPIC. And it was designed by Dan Ford, the Vice Provost for Research. And it rolled out in the health system maybe the middle of October. Some clinics don't quite have it yet, and I think Bayview's not one. But it includes a module about smoking cessation. So some of you might be in health services where hospitals are required to ask their patients, do you smoke? Well, the module, like Catherine's program, asks the 5 questions about the 5 A's, so you can put people into the the continuum of being ready to quit, and we're waiting to see how this rolls out. There is provider education that's needed. It's changing the mindset about whether or not this is something they can do in their office routine, whether they can involve other folks from their office. So, planting the seed, making the referral go more smoothly and so forth. So you'll be hearing more about that. But I think the pharmacy intervention is really, really unique and, not always one that patients hear from. Other questions?
I have one. I think I can just
For the purposes of our recording.
Thank you for your presentation. Thanks. First of all, I'm a MPH student here, and I'm not so familiar with U.S. healthcare system so far. My question is, what makes the difference before and after including pharmacist as a part of healthcare provider? I mean, is that illegal for the pharmacist to providing the consulting? I mean, the tobacco cessation consulting for the patient?
So it sounds like your question is how are we able to, without the legislation passed currently, how are we able to provide a pharmacist-driven intervention? Does that sound correct?
Yeah.
Okay. So we actually act as part of our multidisciplinary group. We have a medical oncologist that oversees the program as well. And from a research standpoint, she has approved all of our materials that we use in the decision making for our patients and oversees our patient activities. And through this research and her guidance, as well as the guidance of a nurse practitioner that also covers for her, we were able to provide the intervention. Does that answer your question?
Yeah.
Sure.
May I have another one?
Sure.
It's sorry. It's back to the research you do. I'm just curious about how you find the target population. I mean, for example, you mentioned they have 3 criteria. The first is the age is less or equal to 65 years old. Extra, those 3 criteria. How you find that? And also you mentioned the p-value is smaller than 0.1. So what's the null hypothesis here? Comparing to whom? Sorry.
No, that's fine. For that survey study that they completed, they identified their current population was significantly for patients who were less than 65 years old. They were less educated and they were uninsured or were enrolled in Medicaid. For our program, those aren't criteria for ours. Our sole criteria are that they are being seen in one of the available clinics that we cover. And then they only have to be active smokers or former smokers who have quit within the last 90 days. And we usually find that out per our assessment. But that's a great question and clarification. Thank you.
It's interesting, the vulnerable population idea and trying to ascertain who that is, who might in usual record keeping just show up as a non-smoker or a former smoker. I think that's going to be a challenge. and Catherine's data will shed some light on, how often that happens and how vulnerable they are, quantify it. Well, I thank you all for coming today. There is some pizza out at the gallery, so please join us for some refreshment. Thank you.
Thank you all.
Catherine.